I'm Goedken, and I'm an associate professor of obstetrics and gynecology at Emory University in Atlanta, Georgia. And while I've been fortunate enough to be able to incorporate my passion for global health into my career, most of my day-to-day activities revolve around caring for the women in my community and training the next generation of providers to do the same. COVID put a halt to my global activities in 2020, but an opportunity arose for me to re-engage and show leadership nationally on an increasingly important ethical and educational topic. The topic is very nuanced. I'm going to try to distill it down for all of you in the next 2 to 3 minutes. It probably would not surprise or alarm any of you to learn that an orthopedic surgeon would use the opportunity to teach a student or a resident about the anatomy of, say, the knee, while in the operating room with the patient asleep, making it actually more comfortable for both the patient and the trainee. On the other hand, in my line of work as a gynecologic surgeon, the same very important anatomic teaching goes on, but understandably, the reaction may be quite different. The fact that a few extra hands may be palpating a uterus and ovaries for the sake of education is surprising to most, and for some women, frankly, alarming. This difference came to light as I was beginning my academic career through an article in the Wall Street Journal that first introduced this practice to the public. A national debate ensued with lawyers and ethicists discussing this topic in public forums, and not surprisingly, medical educators being largely silent. During a panel discussion for the Association of American Law Schools, I tried to defend the practice by focusing on the need to normalize and thus improve education around women's health and their bodies. But my message fell mostly on deaf ears, and I could not and did not try to explain why consent wasn't routinely requested. The American College of OBGYN swiftly responded to the article and debate with a press release calling for gynecologists to get consent for such teaching exams. So that seemed to be it. The debate died down, the box was checked. This would be the new norm. Fast forward to 2017 with Harvey Weinstein and the real awakening of the Me Too movement, and suddenly an even brighter light was shown on this common practice, which had continued without change. In other words, mostly without the knowledge or explicit consent of the women patients. In short order, there was a small explosion of public debate. Phoebe Friesen, a bioethicist and colleague at McGill, wrote this article for Slate. My law colleague, Robin Fretwell Wilson, who I mentioned previously, who had relocated to the University of Illinois, wrote this article for the Chicago Tribune. And then in February of 2020, the New York Times had the article, "She Didn't Want a Pelvic Exam, She Received One Anyway," in which both Robin and I were quoted. Clearly, the academic OBGYN community had failed to heed the call from American College of OBGYN and, most importantly, the public. So a culture change was needed, and I wanted to be a part of it. But before that can happen, the public, now more keenly aware of the prevalence of sexual abuse and assault, took matters into their own hands and pushed for legislation to ban unauthorized pelvic exams. As you can see, prior to 2018, only a handful of states had such laws. After 2018, the numbers more than doubled. While this was definitely an alarming trend, at least in the eyes of the small community of academic OBGYNs, it was the Florida statute that took things too far in requiring written consent before any pelvic exam done by anyone. So having nothing to do with trainees, if you went to go see your own provider and they needed to do a pelvic exam for, say, your annual exam and pap smear, you would need to give your written consent. And if you didn't, or they didn't request it, there was a potential loss for licensure. This was clearly a dangerous step that my colleagues from the VA National Center for Ethics and Healthcare and I discussed in our commentary, which we highlighted the potential for this to create real barriers to women's healthcare and diminish the patient-doctor relationship. This galvanized me, and with the help of my interprofessional colleagues, Robin and Phoebe, we led a charge to stop this dangerous trend towards overreaching laws. We sent a strong message to Florida lawmakers encouraging an amendment to the law, which thankfully passed and was enacted just this month. And the law now reflects language more in line with other states. And while this felt like a big win, it is truly just the beginning of a long journey. Because the law will not change the culture of medical education, nor should it. Medical schools and educators should And this needs to happen now more than ever, because the reality is the burden of medical education is disproportionately borne by people of color. While we may not be able to address all the inequities in our healthcare system, transparency in our practices, clinical and educational, is paramount to respecting and protecting all women, especially those of color. The next steps for the leadership team I have helped create is to focus on the medical education community, because we have to get it right this time in order to respect and protect women's autonomy, as important to foster their trust in the healthcare system and to ensure training of the next generation of competent women's healthcare providers. Thank you.